dementia, connecting our lives to help us survive, so we spend our time to the fullest we can.
Hi, welcome to Professional Insights, created by Dementia Action Alliance. I'm proud to be your host, Laurie Scher. During our Professional Insight podcast, we have educational conversations with professionals in the dementia community to provide answers and support to people living with dementia and care partners. My guest today is Dr. Brian Appleby. We will be exploring why is it so difficult to determine a dementia diagnosis. Dr. Appleby is professor of neurology, psychiatry, and pathology at Case Western Reserve University and University Hospital's Cleveland Medical Center. Dr. Appleby is a neuropsychiatrist who treats and researches neurocognitive disorders. His clinical and research interests include prion diseases, frontotemporal lobar degeneration, and Alzheimer's disease. He is leader of the Cleveland Alzheimer's Disease Research Center's Clinical Core and co-leader of the Neuropathology Core. Dr. Appleby is also chair of the Scientific Advisory Board of the Cleveland chapter of Alzheimer's Association. Wow, Dr. Appleby, that is a huge, huge amount. And welcome. Thank you so much for being here.
Well, thank you, Laurie, for having me. I appreciate it.
And I appreciate also you telling us, just call me Brian. You know, I'm with you. Just call me Laurie. Forget all the little details. But so I appreciate that as well. It seems more hometown that way. I have so many questions for you, and I know that our viewers have more questions probably, and we'll have more questions answered during the dementia discussion later on. But I'm going to start with, Brian, we have many people in our groups who have been given 2, 3, and as many as 5 dementia diagnoses, different types. Why is it so difficult to determine the type of dementia?
Yeah, it is difficult to determine the type of dementia. And in fact, that's kind of one of the last steps. First, it's the neurologist or whoever you're seeing determining what degree, if any, cognitive impairment you have, right? Because there's a continuum. So there are some people that are cognitively normal, and normal really mean normal for that individual. And then sometimes people can notice changes in their memory, but when we test them on memory tests, they score normally. So we'd call that subjective cognitive impairment. And then there's a group of people that may actually have memory problems that we can test and it's abnormal, but they're going about their day-to-day life without any problems, without any functional problems. We'd call that mild cognitive impairment. And then there is a stage, unfortunately, where people have problems with their memory. We can see that on testing, but it is affecting their day-to-day functioning. And that is what we would call dementia. Now, most people, when they develop forms of dementia, it's a progressive illness. And I hate to say this, but one of the most helpful tools that we have as neurologists for diagnosing these conditions is time. Because time allows a clinical syndrome or collection of clinical symptoms to develop that allows us to possibly identify what's going on. So unfortunately, sometimes the clinician may need to follow you over time to kind of know what your clinical trajectory is and see how symptoms evolve over time. And you may start out looking like one thing, but then looking like something else later on. And so that's one problem. The second problem is we really don't have a good diagnostic test for many of the dementias. We do for Alzheimer's now. And of course, we know that CMS has now approved amyloid PET scan. So I think that will help diagnose people even more. But we really don't have what we'd call a biomarker of these other dementias that's as reliable as, say, amyloid PET scan. If we did, it would probably be a bit easier. So that's kind of the long-winded version of why it takes so long to get to the final diagnosis for some people.
Thank you. That's very helpful. It's really very difficult as a person knowing you have some kind of cognitive issue, but going through diagnosis after diagnosis. It's really difficult. But are there steps or information that, as a person living with dementia, we could possibly provide a doctor to help clarify the symptoms? What should we tell them, or what do we need to be looking for that would help the doctor?
Yeah, those are excellent questions. What I usually tell trainees is there's kind of two questions that they should ask that is going to help them narrow down 75% of what's going on. And those two questions are, how did things start? And then the second one is, how did it progress? Right? Because if someone says, oh, all of a sudden I had memory problems on such and such day, and it hasn't gotten any worse or any better, well, that helps you, right? That kind of sounds like something happened to that person, like an acute event, like a head trauma or a stroke. But if the patient says, oh, well, I can't tell you exactly, but over time, I seem to have developed some memory problems that have been progressively getting worse over time. And also, now that I think about it, I have some problems coming up with words. Well, that leads you down the track of, say, Alzheimer's disease. So if you can just show up to a physician's office and answer those two questions from the get-go, whether or not the physician knows to ask those questions, it's going to really help them narrow down what's going on. At least to know where to start asking questions and where to look.
Oh, okay. Um, and I know we go through a lot of testing when before a doctor gives you a diagnosis. There are many, many different types of tests. But as a doctor, what are you looking for in an MRI, in a PET scan, in a CAT scan, and in a spinal tap? How are they relevant in the diagnosis process? So what are you hoping to narrow down through those tests?
So a couple of things. Probably our worst fear is not catching something that's treatable, because obviously that would tremendously impact a person's life. So the first thing we're looking for is treatable conditions that could be causing your symptoms. So that includes things like thyroid problems, vitamin deficiencies, infections, even depression can sometimes mimic these cognitive and memory disorders. So a lot of the workup is focused on trying to find those treatable conditions that you would do something very different about. And then assuming all of those things have been ruled out appropriately, then you're starting to narrow down, well, what else could this be? So as you said, a brain MRI can be helpful to differentiate, number one, whether or not there's things going up in the brain that shouldn't be, like blood vessel disease, whether that be a stroke or just wear and tear of blood vessel disease over time, which can certainly result in memory problems. Or we also look at the way the brain shrinks over time. All of our brains shrink as we age, unfortunately, but it should all age or all shrink at the same rate. So in other words, the front part of your brain shouldn't be shrinking faster than the back part of your brain. So by doing that, sometimes we can help what we call localize or detect a region where a disease process might be starting. So for example, if the front part of the brain is smaller than the back part of the brain, that could be indicative of something like frontal temporal dementia. And then the other things we do with more sophisticated biomarkers, like a spinal fluid analysis from a spinal tap, is a lot of times we're still looking for treatable things, because there are things that we can only detect in the spinal fluid that you're not going to detect in the blood. But then also that's where some of the markers for Alzheimer's disease can be checked as well. So they're probably going to be looking for that. And then, of course, nowadays, I think we'll hear increasingly more about providers using amyloid PET scans to detect, markers of Alzheimer's.
Okay. I know of a number of people that have had really bad reactions with spinal taps, but you do feel as though spinal taps are kind of important in the evaluation process?
I think it depends on the patient. So my main field is something called prion disease, which is a rapidly progressive dementia, unfortunately. So that the time from onset until someone passes is 4 to 6 months. Very, very quick, very horrible illness, but also it mimics a lot of other treatable illnesses. So the only way to really get at that is through a spinal tap. So in a case like that, certainly. But again, in the case of a gradually progressive illness that's kind of slowly moving over time, again, nowadays with the amyloid PET scan, you can kind of get the same the same answer. Before, the amyloid PET scan wasn't really covered by insurance, whereas a lot of the spinal fluid tests were. So I think that's why more people gravitated towards that. So I think, starting this year, we're going to see more and more people gravitating towards maybe an amyloid PET scan as opposed to a spinal tap, unless it's one of those unique situations that I mentioned earlier.
Okay, that's good news. For many of us, that is good news. And Brian, you know what? I see a lot of us, we average probably 15 people per discussion group that we have. So there's probably, close to a couple hundred of us that are living with dementia that circulate throughout our groups, maybe 300. And we talk a lot. We talk about our symptoms. We talk about what the doctor says, etc. And we learn a lot of strategies and symptoms from each other. So if the doctor diagnoses me with Alzheimer's, but based on what I'm hearing from everybody else, I think these hallucinations, and I really think this is more Lewy body dementia. How accurate is a diagnosis process? And if we feel as though the doctor perhaps was incorrect or needs to do a reevaluation, what can we say? How do we say to a doctor, I think you're wrong, politely?
Yeah, no, I mean, I think one thing to be aware of is we have a shortage of dementia doctors in this country. So the amount of people that are actually seeing doctors who do this every day are actually pretty small. So it's very likely that the person that you're seeing may not have a whole lot of expertise or experience in that. But you're around a lot of people that unfortunately have personal experience. So, and again, doctors are like other people. Some will be open to discussing things, some won't. That's, just like a plumber or any type of technician, right? But I do think there's a way to approach it and say, just be honest, say I'm part of a group and, one of the members of the group had these symptoms and their physician thought maybe they had this. What do you think about that? Because I have these symptoms. So there's a way to politely do it. And, we need input from the patient and from the patient's family to help guide us on the diagnosis. So we do need that two-way communication in order to help you. So you should feel free to bring up these concerns.
Okay. And reevaluation, would that basically just be additional tests, do you think, or re-looking at the old test? How would you reevaluate somebody, would you think?
I think it depends on the person. So for example, it could be that I'll give you an example here. You have someone who is younger, has symptoms of frontal temporal dementia, right? And they may even have an MRI that looks a little bit like frontal temporal dementia with some shrinkage of the front part of the brain. But they go to one of these groups and they find another young individual who says, well, I have all those symptoms too, but my physician found that I had a atypical form of Alzheimer's disease that can sometimes present with frontal lobe symptoms. So in that situation, it would be going back and the physician may say, well, it's a good suggestion. We have a test for that. Let's check and see if you have, a frontal presentation of Alzheimer's disease. So I think that would be the best scenario because again, we have a disease defining test in that instance. A lot of the times, if that's not kind of the situation, it may be just looking at how the patient has progressed over time again, right? So again, time is the best diagnostic tool that we have outside of these disease-specific biomarkers, of which we really only have for Alzheimer's.
Wow. Okay. Brian, I just really want to thank you so much. This has been a lot of information. I can't wait to hear what questions everybody has for you and hear you talk more about this. But thank you for being with us today and talking to us, helping us to understand why it's so difficult to determine a diagnosis.
Thank you, and thank you for what you do.
And I want to thank our viewers for being here. Dementia Action Alliance is committed to enhancing lives, connecting people, and increasing understanding. So thank you for joining us. for our professional insights. More podcasts and valuable resources are available at daanow.org. You can help continue these podcasts and other programs that enhance the lives of the dementia community with a donation to daanow.org. Thank you. Enjoy your day.
Live our life to the fullest. We can.